I want to talk to you.
Not now, later.
No, now.
Talked a little bit about medical optometry. Can you talk a little bit about its prevalence today?
Yeah, absolutely. I think medical optometry is really shifting our profession as optometrists completely. I think many decades ago, before we were in school and before we were practicing, you could really only practice medical optometry in an ophthalmology setting or a hospital setting. And so, whether that was due to scope and state laws or whether that was due to billing and reimbursement, I think that over the past couple of decades, optometry has really shifted to now where there's more of a focus of medical optometry. So, whether that's focusing more on the glaucoma, the medical management of glaucoma, and in certain states, we're able to perform lasers, SLTs, and YAG PIs in certain parts of the country. So I think that really helps also the image of optometry as well.
What are the benefits of scleral lenses?
Scleral lenses have a lot of benefits. So what we use them for in clinic mainly is patients who have not found success with traditional glasses or soft contact lenses, or even other types of rigid contact lenses where they might be uncomfortable. And what these can do is they essentially create a new ocular surface for you. So the front of the eye, if it's damaged from a condition like conus, corneal transplants, radial keratotomy, different things like that, you can actually rehabilitate and provide a new, better surface for that eye with the scleral lenses. They're also a really great treatment opportunity, as I said before, for dryness. And in really severe cases, Sjogren's syndrome, Stevens-Johnson syndrome, and a condition called graft versus host disease, the front surface of the eye is really damaged from just basically insult and this condition, injury. And you can rehab the eye and actually heal the front surface of the eye with these lenses.
What other eyelid conditions can contribute to dry eye?
Aside from having lashes, we have little oil glands that have their openings right on that lid margin. So if you can imagine, having those oil glands get capped up can also create a big issue, because the oil layer that those oil glands create are what keeps the tears from evaporating immediately off the surface of our eyes. So things like chalazion or hordeola, or more commonly known styes, are big issues for people, but they stem from things like ocular rosacea or having meibomian gland disease. So all of these things kind of tie together. It's just some people will experience some version of it and not realize that they went together in the first place.
Dr. Lifford, could you go into a little more detail exactly about glaucoma and the potential causes for the condition?
Yeah, what can I tell you about it? It's it's a relatively common condition in that it can affect patients of all ages more as we get older. And the problem is it can be undetected, both by the patient that doesn't have any symptoms, and by the provider, unless we're looking for it, it can be easily missed. Usually it's related to higher elevated intraocular pressures, but there's a fair amount of patients who have glaucoma and with pressures in normal range. So we can't use that as our main guide for diagnosing glaucoma. It's usually related to higher eye pressures, as I mentioned, though, and it can cause damage to the optic nerve, which can affect parts of our side vision. And it's irreversible. So ideally, the earlier we could diagnose it, the better the prognosis.
Could you go into it a little bit further about what causes eye allergies?
Yeah, so depending on the time of the year, so usually in the spring and fall, it's usually things outside. So the pollen, whether it's from tree or plants, dust is a common issue, especially in the wintertime, because most of us are indoors. So if I can recall my textbook from when I was a student, I think it's around 28% of allergies in the winter are dust. And then 24% in the wintertime, surprisingly enough, is cockroaches. And I remember that because it was such a weird thing. And I was like, cockroaches, really? And I've had at least one patient before who they had an allergic response, a really severe one, to cockroaches where they were living in. But outside of dust, bugs, and again, usually spores outside, that's most commonly the issue for the eyes. Things like, grass season. Down in Texas, where I used to live and went to school, they had what's called Cedar Fever. If you ever heard of that, but it's, the cedar trees release their pollen and you see cars are like almost a yellow color because of all the pollen in the air. Those are usually the biggest culprits, but you can have allergic responses to medications. People who wear eye makeup can have allergic responses to that. Basically anything that you put on your skin can cause these issues.
You talked a little bit about ocular oncology. I was hoping that maybe you can explain that a little bit further for some of our viewers who may not know what that is.
Yeah, absolutely. I think the first question my patients always ask me once I've given them a diagnosis is, what do you mean you can have cancer in the eye? They didn't even know that existed. And not only can you have cancer on the front of the eye or on the inside of the eye or even in back of the eye in the area called the orbit, there are multiple different kinds of cancers. And I treat many different kinds of cancers. I would say the main ones are a type of cancer that occurs in very, very young on the inside of the eye. That's something called retinoblastoma. And in adults, I treat a lot of melanoma. Melanoma, of course, is much more common on the skin. And it is a cancer, but it's a cancer that can affect pigmented cells all over the body. So you can have them affect pretty much any structure in the eye where there are pigmented cells. That can be in the front of the eye, the iris, or in the area inside of the eye called the ciliary body or the choroid. And I also treat some sun-related cancers on the front of the eye, like ocular surface squamous neoplasia. That's another common one that comes to my clinic.
Can you tell us a little bit about some of the conditions you regularly see that can benefit from custom contact lenses?
Yeah, I mean, there are so many again, but probably the most common specialty type of condition would be keratoconus. And because it's such a common condition and they do so well with custom like rigid gas permeable lenses, whether scleral or corneal, that that's probably the one I see the most of. But of course, patients with dry eyes, patients with like just very high prescriptions, whether it's astigmatism, hyperopia, myopia, patients with corneal transplants or previous surgery, scarring, anything like that.
Dr. Styes, can you tell us a little bit about what pre-op and post-op protocols you recommend for patients and why it's important for them to have better outcomes?
Yes, to have the very best cataract surgery outcome, we really want a stable tear film. We want a healthy cornea and very clean eyelids without bacteria and Demodex present. And that's going to give us the very best accurate measurements that we're going to take when we're selecting that premium IOL. So we really want to make sure that we address the dry eye prior to surgery. And we also want to make sure that we really clean the lids and lashes well before surgery to prevent any risk of getting a really bad infection during the process. So I like to follow the DEWS 2 protocol, which is educating the patient on dry eye. We would change some lifestyle and diet things. We're going to apply warm compresses to the front of the eye, and then really address the lid cleaning with lid wipes and lid foam, possibly hypochlorous acid. I like to use a lipid-based artificial tear, such as Retain MGD, one of my favorites. Sometimes the patient might need nighttime ointment or nighttime goggles to protect the front surface of the eye. Then, of course, we have wonderful prescriptions we can write: Lafritogras, cyclosporin, autologous tears, biologics, or loteprednol. And then there are also a lot of in-office treatments we can do, from a lid cleaning to even a warming up the lids with a thermal process, and then expressing those oil glands. So all of those are going to be really important to have the best surgical outcome. Is
there one in particular that's your favorite that you're really passionate about?
Right. I can honestly say when we're able to, one that's near and dear to me is myopia management. Growing up, my eyesight was terrible. I became more nearsighted by the year. And to be honest, even in graduate schools, I was still becoming more nearsighted at that point. As a result of that, my retina is a little bit thinner than the average. I'm more prone for detachment, tears, and holes. So that is very near and dear to me. Being able to treat children as young as 5, 6 years old with either medical management or specialty lenses, and to not have a high prescription, which means a longer eye. And to not have that debilitating effect later on in life is extremely rewarding. Parents, you can survey around. 99% of parents don't realize that there is an opportunity to prevent their children's eyesight from getting worse each year. So having that global perspective, kind of taking a step back and realizing how much there needs to be education delivered to pediatricians, to parents, to general doctors.
What type of patients do you typically see?
So I love my job because I get to see a variety of patients. I would say most of my patients are in the 60 to 70 and above category, because a lot of diseases that affect the retina have an increased risk with age, with time. So the most common disease I see is age-related macular degeneration. But I also see younger patients who have systemic conditions that can affect their retina, like patients with diabetes. So I do have some young patients that are in their 20s and 30s who have something called diabetic retinopathy, which is where you can get leaky blood vessels from high blood sugars in your retina.
It's funny that you talk about like mask-associated issues. I was actually going to ask you, can you talk a little bit about mask-associated like dry eye and computer vision syndrome? Like, have you seen a lot more cases of dry eye now?
I think so, yes. I mean, remember, dry eye is really an epidemic to begin with. Somewhere between 5 and 15% of the US population has dry eye, and a lot of it is underdiagnosed. But I think definitely with the mask wearing and the screen time, it has gotten a bit worse. So mask-associated dry eye is basically when you're wearing a mask that's not fitted properly, the air is essentially directed right up the top of the mask and like directing the flow of air over the surface of your eyes. So it leads to faster evaporation of your tears, and then you end up with all the symptoms of dry eye, so of which there are many. So to name a few, redness, burning, itching, teary eyes, irritated eyes, feeling like there's something in your eye, off and on blurred vision. So in ways to combat the mask-associated dry eye, I think the number one way is to make sure your mask fits well. So you want to get a mask that has a nose wire, so you're pinching it properly. You want to make sure it's fitted more tightly around your face. If you need to like cinch the earpiece or double loop it, those are ways that will help.
Dr. Bailey, I was hoping that maybe we could talk about the treatment options for cataracts. What are the typical treatment options that we typically would see for that?
So the first one's super simple. We kind of already talked about it, just getting an updated glasses prescription. So, when we're young, we go through a lot of glasses changes just as we're growing. And then we hit a period where our vision's pretty stable. Things don't change much. Then we get to that point where we're having the trouble up close and focusing up close. And then you start having all of these prescription changes because the cataracts are just progressing and changing your vision.
Can you explain what exactly is LASIK surgery?
Yeah, so it's a great question. So LASIK actually stands for laser assisted in situ keratomileusis. So in layman's terms, what that means is LASIK basically uses two lasers to reshape the surface of the cornea or the surface of the eye. So the first laser is a femtosecond laser, and that is used to create a flap of tissue on the cornea. The surgeon then lifts that flap, and then a second laser is used to treat the actual cornea underneath it with the patient's prescription. The surgeon then puts the flap back down, smooths it out, and that's it. That's LASIK.
Dr. Cheyenne, what's involved in myopia management?
There's a few different approaches to it, but ultimately the end goal for each of the different types of treatments is to slow down that axial length, that growth of the eye. And I'll be happy to kind of go into the different options that we have, but ultimately that's what we're trying to do is we understand that the length of the eye is what causes that change in the prescription and the change in vision. And there are some techniques that slow down the change in the prescription, but they don't slow down the change in the length of the eye, and ultimately the vision will rebound and go to a point where the prescription increases. But the treatments that slow down the increase in the size of the eye are the ones that tend to be more effective in the long term. So that's what we're usually targeting.
Dr. Khan, I'm interested to know, and I'm sure our viewers are interested to know, what exactly is a tear trough expert?
Yes. So, tear troughs are basically the anatomical region that we call right about here, where essentially your tears would collect. As we know, our tear duct system, it starts from our upper and lower eyelids, from the puncta, and then it kind of merges inside at the lacrimal sac, and then it drains into the nose or the back of your throat area. But what we find is that there is kind of a little notch here where just the way the bones and the soft tissues kind of merge there, where the tears would collect. But basically, I think the term has become popularized over, the last several years because it's a popular place for filler injections. So, we notice that people have what we call a tear trough deformity, where it's just a little bit hollower right in that nasal third of the lower eyelid. And it's usually just due to the normal, things like aging and not getting enough sleep, not drinking enough water, and the skin there just tends to thin out.
What exactly is OrthoK?
Yeah, OrthoK is a treatment that is able to temporarily eliminate the vision defects during the day. So you put on the specialty lenses during the night when you go to sleep, so you can see clear with the lenses on for see the television, or go to the restroom. And next, in the morning after, you can remove them, and you can see clear, you can see well all day during the day without glasses or contact lenses. So it's a very nice solution for those patients that have some myopia or hyperopia or astigmatism or presbyopia also. So you put on your lenses during the night, and the next day, the day after, you can see clear without nothing. So you can do some sports, you can do your life more free than before.
Dr. Mighty, we were hoping you can explain the correlation between dry eye and the use of cosmetics and skincare products. Can you explain that to our viewers a little bit?
Yeah. So what's actually kind of interesting is I think this is sort of a sort of newer area of interest, particularly for eye doctors, where for many years, even though we knew dry eye and ocular surface disease was a thing, I think a lot of doctors didn't really consider that these products our patients are literally putting on the surface of our eye, that they could have any impact on the ocular surface. And when you think about it, you're like, of course, people are literally putting these chemicals on the eyelid margins, on the eyelashes. Of course, they have the potential to impact our meibomian glands that are right at the edge of the lid, to get into the tear film or affect the tear film. So I think it's a very under-researched area that more doctors and researchers are only really starting to realize, within the last 10 years, maybe, that this is something we really need to pay attention to, that absolutely could impact our patients. And they're doing all these potentially toxic things to their eyes without realizing it.
You talked about the type of sunglasses that you would need to wear when you go outside, and like the protection that you need to wear. But what kind of damage can the sun do to our eyes?
Well, I mean, UV light can have a lot of negative effects on oxidation in and around the tissue. So first and foremost, it exacerbates existing conditions. For example, people that have allergies or people that have dry eyes. The UV light can basically damage some of the tissue, cause more inflammation, which in turn exacerbates that allergy or exacerbates that dryness. You also will start to see some damage to certain tissues on the white part of your eye. We call that the conjunctiva. So it's that little kind of squint zone. We call that the inner palpebral zone. And that tissue will harden almost like a callus. So that oxidation of that tissue will harden, and that's somewhat irreversible. When that starts to happen, if the eyes aren't lubricated, if they're not, free of kind of some of these radicals, that the light and UV light can cause, then that tissue will stay permanently like that.
I make it educational so that the people learn something, but I also make it so it's entertaining. And I do that in simple things like accents. And I don't know if you know what that means, but
you could explain it if you want to.
So when I was teaching at the university and the students were not paying attention, who knew? Students don't pay attention sometimes. They drift off, they text, I don't know. I just throw in an accent to describe something. Like, let's say I was talking about a case and a patient comes in with a very bad dry eye or whatever. And then I decide to create that atmosphere of the actual patient being in the exam room by changing the accent. So one would be, let's say, a Russian accent. So a 65-year-old Russian female comes in with problem with eyes. She's using her eye drops 29 times a day. She said, Dr. Nanda, please to help me. I said, I try. Well, I don't say it like that, but I was like, okay, maybe I can try. Or I can switch to a British accent like that, and then I say, have a cup of tea and maybe some drops to go with it, or rolling your R's with a Scottish accent. It's a little bit harder to do, but you have girls and lasses and you don't even understand why they're not wearing the glasses, but whatever.
Dr. Yaldo, for our discussion today, we were hoping that maybe you could discuss a little bit about styes. So can you tell us a little bit about what they are and how they develop?
A stye is when one of the oil glands or sweat glands around our eyelashes gets infected and bacteria builds up in there, forming a bump on our eyelid. Our eyelids, the upper lids and lower lids, have oil glands that supply an oil to coat the front surface of our eye and protect our tears from evaporating in between blinking. So that way we can see while in between. So sometimes the oil glands do get clogged up and it can be infectious, called a chalazion. And those are generally not tender. They get bigger over time, but they don't bother you. Sometimes if you touch them, they do. That's called a chalazion, and that's non-infectious.
Dr. Stu, can you let our audience know why it's important to have these exams?
Well, it's important because kind of the reason we just said, the naked eye, you could be the best doctor in the world. At the end of your exam, the doctor will typically chart what they're finding, but it's not the same as putting an actual image on file or a scan on file and the doctor referring to those images. So long-term, it does allow for much more thorough care, but also comparison of yourself as you age, as most eye diseases do become more common as we get older. So having this type of exam is key to establish, the health of your eyes as a baseline for all future comparisons.
What exactly is an optical and why is it so important in eye care?
So most of the time when a guest comes in, they want to just find glasses so they can see, right? So that's like the first initial reason why they come. So an optical is kind of like the gateway to accessing patient care. So a lot of times patients come in, they don't even realize anything is wrong with their eyes health-wise. They just want to see. And from there, we actually catch diseases for the patients. So an optical is different, but also very, very important in eye care because from them, the patients get their eye care. And you can just go in and come in and say, hey, I just need an adjustment in my glasses, but it turns out something much more extreme is going on, or hey, you actually just need a little adjustment in your glasses. So the opticals is the gateway for that.
What exactly is astigmatism?
Yeah, so I'm actually going to take this direct quote from the doctor that I work with. She tells patients all the time, when you hear astigmatism, you hear ism. So you think it's a disease, and in fact, it really shouldn't be thought of that way. It's something very common that a lot of people have. But what it is that front part of your eye, or just your eye in general, instead of being perfectly round, it's not. And so when light hits the front part of your eyes and focuses on the back part to give you a clear image, the light kind of scatters a little bit, causing your vision to be a little blurry.
Can you talk a little bit about what these vision screenings are? What exactly does that mean, and what relevance does it have to kids going back to school?
Vision screenings are great. They are tools to help catch any undiagnosed health or vision issues seen in the kids. They're usually performed in either the pediatrician's office or sometimes at school by the school nurse. They're a great screening tool to kind of detect if there's something wrong with the vision in children, but it's a fast, quick exam. It's a great way to go through lots of kids at a time and catch anything that they miss.
What exactly is an occupational eye exam?
Great question. So an occupational eye exam, sometimes can kind of sound scary because many times when you hear this, many patients that are going to get one have to pass it in order to get whatever endeavor they're trying to achieve. And so an occupational eye exam essentially is a complete eye exam with some additional testing that's required based on the occupation you are trying to get yourself into. So there will be certain special tests that are going to be required that might be specified just for that field, or additional tests that we typically don't do on adults general comprehensive eye exams. And they're going to be looking at those things, and you'll have to hit a certain marker to pass to be eligible for that occupation.
What exactly is cognitive vision testing?
Yeah, thanks for asking, Nick. So this particular topic is a very high level one at this point. So cognitive testing, to give you a Cliff Notes answer, is quantitating the processing of our vision. In eye care, we do a lot of testing vision. We do a lot of preserving vision. But there's so much more to vision than just the vision received. There's a lot of processing that takes place throughout the brain. And we now have the ability to quantitate that capability. And it comes in various forms. But right now, the most popular and that which I personally utilize is a technology called Cognitive Thrive, or CogniView Thrive. And so cognitive vision testing is the ability to quantitate our ability to process that vision. And it's really cool because, as you can see in the industry, a lot of eye care professionals are seeking modalities above and beyond just vision, not just to set themselves apart, but to more importantly, better care for their patients.
Dr. Gupta, when it comes to seasonal allergies, what's the recommended advice that you give to patients? Like, do you have like a course of treatment that you go through with them?
Yeah, so it really depends on what part of their body is affected. So like I said, the eyes, the nose, the airways, and the skin can all be affected by allergies. And so it's really dependent. My treatment plans are really dependent on what symptoms the person is experiencing. So for example, for the eyes, if people are having those itchy, watery eyes, then we have antihistamine eye drops that people can use. We also sometimes recommend eyelid kind of washes or scrubs, kind of, similar to the ones that OCuSoft makes. And that's mostly to get rid of the pollen and anything that's sitting on your eyelids, because the longer an allergen sits there, the more irritation and discomfort it can cause.
When is surgery recommended to treat cataracts?
Surgery is recommended anytime your daily activities are being impacted by your vision, and that is deemed to be from a cataract. And so it's really important for patients to get in and see their local ophthalmologist and get a detailed, thorough exam to figure out, is the cataract that's causing the vision changes? Is it something in the retina or something on the cornea? And they can walk you through all of that, take some measurements, and talk to you about your choices and lens options.
What causes childhood cataracts?
That's a very good question. So, as I mentioned, there are a number of various different reasons why a child could develop a cataract. Broadly speaking, we can break it down into what we call congenital, i.e. somebody who's born with cataracts, and also acquired, somebody who develop a cataract later on, maybe because of some sort of trauma or some sort of inflammation in the eye, and a variety of reasons. But I think broadly speaking, we can talk about congenital ones and acquired ones.
What exactly is uveitis?
So uveitis is essentially defined as intraocular inflammation. So inflammation that's occurring inside the eye. The main structures that are affected are structures that we call the uvea. That's why it's called uveitis. Uvea, these structures, itis meaning inflammation. So the structures that are mainly affected are the iris, the ciliary body, and then in the posterior part of the eye, the choroid.
So we talked about the different stages of diabetic retinopathy, but what are the treatment options that are available?
The best treatment option is early detection and patient education. Because remember, we just went through this whole cascade of events. It all starts on everybody with just that one little teeny tiny drop of blood that should not be there. So what would I do with my patients? I will review their A1C levels with them, and more often than not, right? Even when I'll go to another specialist's office, sometimes I'll be afraid to ask, hey, what does that really mean? I don't really know. And with diabetes, if you don't know where you're at with your blood sugar levels, how can you ever improve, right?
Let's say now that I've decided to go see a doctor, like something's going on. What should a patient expect when they go see you for their appointment?
So for the appointment, so essentially we start everybody off with a dry eye assessment. Then once, if you are doing radio frequency, how it starts is usually about 45-minute appointment. And then we have one of our techs start off by treating the periocular area, which is like the area around your eye. So they use this probe, which is about a dime size. It's like metal, and they rub it around your eye, and it feels like a hot stone massage. So it feels nice, but what it's doing is it's warming up the tissues around the eyelid, so there's less treatment time on the eyelid itself. So then once that's all warmed up, it takes about 7 minutes. I go in with a probe and I treat over the eyelid itself. Now this also feels like warm metal kind of going over your eye. Generally it feels comfortable, and there's ultrasound gel that's over it, so it's smooth there, but it can get uncomfortable or get a little bit hot at certain points. But I always tell my patients, we got to understand that we are treating a disease right now. Like as much as we'd like to make it feel great, there's damage that we're trying to work on. So that little bit of discomfort that you might experience for about 5 minutes is outweighed by the huge benefits that you get afterwards.
Are there any patients that are kind of like more likely to develop a detached retina?
Definitely. So one that you'll hear quite often is high myopia or very nearsighted patients are unfortunately at a higher risk of retinal detachment than the general population. Some other findings that you might see that predispose people to retinal detachments are things like lattice degeneration, peripheral retinal breaks. We mentioned trauma. Of course, if somebody's had a prior retinal detachment, they may have a lifetime predisposition to it. Family history of retinal detachment, and actually even some systemic conditions can put people at a higher likelihood.
Are there people who are more likely to suffer from macular degeneration? Or is there someone who's going to be more at risk for this?
Yeah, I mean, as the name implies, the main risk factor is age. Those aged 55 and older are much more likely to develop age-related macular degeneration. But we found out that genetics also play a significant role. Research over the years has discovered multiple genes that have been related to developing macular degeneration. And therefore, having a family history of this condition is definitely important and increases your risk of having it. Other factors, smoking, those with the lighter skin and lighter eyes, obesity, and those with cardiovascular disease, such as high blood pressure, can be a little bit more at risk as well.
So what are the differences between medical contact lenses and corrective contact lenses?
Yeah, so medical contact lenses are special types of contacts that are fit to the patient's eye. So traditional contact lens, those are kind of mass produced. So you're kind of picking a lens out of your fitting set and putting it onto the patient's eye. Whereas a medical type of lens, there's usually lots of different base curves and diameters and shapes and sizes to really able to kind of customize the lens to the patient's eye. A lot of times it's made out of a different material called a gas permeable material. So instead of being soft, it's a kind of a more rigid type of structure, and that provides a smooth optical surface and helps to correct for some of that irregular shape of that person's eyeball.